Okay. Well, I'd like to thank everybody for surviving the trace amounts of snow, which apparently has ended all travel in Seattle as usual. Actually, I've got a great photo of everybody watching. Like in Seattle, 4 inches of snow means Armageddon, the world shuts down, and then life is over. And in Green Bay, Wisconsin, 4 feet of snow means aerobic classes get canceled. So different places have different approaches. Well, it's my honor to introduce one of my partners, Ala Ayub, who's here today to talk to us about renal denervation. Ala actually found out trained in Dublin, Ireland, and then decided to keep with the Irish theme and came to the Leahy Clinic in Boston. And after his training and residency and fellowship at the Leahy Clinic, did a few years up in Maine, and then decided that was too cold and too snowy and decided to move to the other coast with better water and better weather, and came and joined us here at the University of Washington. So it's my pleasure to introduce Ala to talk to us today about renal denervation, past, present, and future options for patients. Thank you, Ala.
Thank you, Bill. Thank you for that kind introduction and for your dedication to our team. So I'm going to be speaking to you today about renal denervation, and you really can't talk about renal denervation without talking about hypertension management and the problem of hypertension. So I'm going to be speaking to you a good bit about that as well. So this is the mandatory slide from UW Medicine saying that I have no financial disclosures. The only disclosure that I do have is that we're going to be discussing off-label use of devices. And I say off-label because these devices are not yet approved for use in the United States, although that is likely to change soon. So this is the scale of the problem that's ahead of us. So this is relatively old data from 2010, but shows what we know is the current magnitude of the issue, and that is that a quarter, so in some estimations, a third of the world's population suffers with hypertension. And a quarter of those are from high-income countries, but the vast majority are actually from low or middle-income countries. And this is a little bit more recent data on the percentage by region. And so close to about 40% of the North American population have a diagnosis of hypertension. Africa only reported to have about 21% prevalence. And there's questions there about screening for that for this condition, as well as looking at Europe, and in France, a reported rate of about 50% of patients with hypertension. Looking at the United States, this is NHANES data from published in 2017, but the data set itself is actually from 2011 to 2014. And what it demonstrates is the percentage of the population for each age group, ranging from about 10% of those aged 20 to 34, and then upwards of 64% of patients who are over 65, and a lot of the patients that we end up taking care of in our clinical practice. And I think the important thing to note here is, of course, that this is a disease of aging. It's much more prevalent as our patients are older. But also important to keep in mind that especially our patients in the kind of earlier stages of life are going to be facing this problem lifelong, and they're going to be on medical therapy lifelong. And that's sometimes a difficult thing to be counseling our patients on in the very short amount of time that we have to spend with them in our clinics, and with kind of ever increasing demands on clinical practice. And so despite the high levels of awareness in patients who have hypertension, again, this is NHANES data, same data set published a few years ago. The patients who do have hypertension are very aware that they do. And despite these high levels of awareness, a significantly lower percentage of patients are on treatment. And then even fewer have actually achieved control as determined or as recommended by kind of societal guidelines. And as a result of this being a kind of a common illness, it places a huge financial burden on all aspects of our healthcare, not only as a primary disease, but also as a risk factor for comorbid conditions across all age groups. And as expected, as age advances, so does the cost associated with either hypertension or hypertension related illness. As we would suspect that patients with the greatest financial burden, the greatest financial burden is in patients who are over 65 years of age. So the treatment for hypertension, and I will get into kind of earlier treatments before the 1950s. I'll touch on that a little bit later in this talk. But medical therapy really started in the late 1950s and started with kind of thiazide diuretics, and then later with the kind of advent of calcium channel blockers, alpha blockers, ACE inhibitors, ARBs, and then eventually the direct renin inhibitors, such as Tecturna, coming along in the late 2000s. And we've had many trials over the past 6 decades to shape our knowledge and understanding of the different medication classes. And this is really kind of helped to shape how and when we use these different medicines. But as part of that, we've been left with multiple societal guidelines from international societies with often confusing or conflicting recommendations for goals and treatment. And we'll touch on kind of one of the controversies of that in a little bit. But hypertension has been called the great orphan of clinical medicine due to the myriad of contributing factors related to its causation, as well as the multiple reasons for inadequate control, whether it's lifestyle factors, clinician and patient motivation to identify, monitor, and treat, the multiple medication choices and dosages, the side effects from each of those medications that are prescribed, and then I think most importantly, patients' compliance with taking prescribed medical therapy. The lifestyle interventions that we have for hypertension work well if they are able to be achieved, but are notoriously difficult to do, as you all know. If we can encourage our patients to be exercising 150 minutes per week of moderate intensity activity, we would hope to see a 5 to 8 millimeter decrease in average blood pressure over time. Patients who can follow a DASH diet can expect to see a reduction in their blood pressure by about 11 millimeters of mercury. Weight reduction for every kilogram, you can reduce blood pressure by about 5 millimeters of mercury. Sodium reduction, alcohol, and then use of CPAP for sleep apnea can all have their own modest reductions in blood pressure. But you could see how if a patient was able to undertake multiple lifestyle modifications, that they could see effective reduction in their blood pressures over time. The key is in maintaining and sustaining those blood pressure improvements over time, and that's been the real challenge in this condition. We do have data that shows us that it is well worth it to lower our patients' blood pressures. We know that with this data set that there's a linear increase in cardiovascular events as the blood pressure increases, but by the same token, if we're able to lower our patient's systolic blood pressure by 10 millimeters of mercury over time, that can reduce cardiovascular events by as much as 20%. There's an association with a decreased mortality of 13%, all-cause mortality, a reduction in development of coronary disease by 17%, and then, of course, Big ticket items, stroke and heart failure can be reduced by up to 27 to 28% over that time period. So even with these kind of modest reductions, there's still much to be gained as far as clinical outcomes. And this was very nicely demonstrated in the SPRINT trial, which showed us that among the patients who are the highest risk for cardiovascular events, but who did not have diabetes, that if we targeted an intensive blood pressure goal of less than 120, as compared to a blood pressure of less than 140, systolic blood pressure of less than 140 millimeters of mercury, which I'll remind you was the guideline recommendation at the time from JNC 8, kind of known as JNC late at the time. But by treating to an intensive blood pressure goal of 120 millimeters of mercury systolic, this resulted in lower rates of fatal and non-fatal major cardiovascular events and death from any cause. Actually, the study was stopped early due to these findings. Do remember, though, that in the intensive treatment group, that there were significantly higher rates of adverse events related to the treatment itself. And this led to things, to side effects, including syncope, electrolyte abnormalities, and acute kidney injury, all things that we encounter when managing our patients in the clinical setting. But it also signifies that this treatment intensity is not completely benign. And maybe a reason why patients don't comply or don't end up maintaining their medical therapy over time. The title of the paper I got this from was called "The More We Prescribe, the Less They Take," and it's a retrospective study of 8,400 patients, managed care patients, with hypertension and hyperlipidemia, and who were prescribed antihypertensive and statin therapy. And as you can see, once patients are prescribed more than two or more medications, the adherence to those medicines decreases significantly. And then once you get to patients who have resistant hypertension and are now on 3 or 4 medications on top of a statin, your adherence is significantly worse. Couple that with decreased innovation, innovative compounds, and so cardiovascular disease has really lagged behind other fields, including oncology, in terms of the development of new medicines and in the armamentarium for against hypertension and other diseases. Although I will say, the Brighton study recently presented at AHA did present baxdrostat, which was an inhibitor of aldosterone synthase, and did have when added to 3 other antihypertensive agents in patients who had resistant hypertension, showed an up to 20 millimeter mercury decrease in systolic blood pressure, which is very impressive and was statistically significant. Just something for thought. So we've long known about the central role of the sympathetic nervous system in the pathophysiology of multiple cardiovascular diseases, not just hypertension, although that's where I'm going to be focusing most of the talk going forward. But understand that this has been found culprit or seen to be culprit in other conditions, including atrial fibrillation and congestive heart failure. And I will talk about the effects of renal denervation on those a little bit later in this talk. The renal sympathetic nervous system comprises a dense network of postganglionic efferent fibers that run from the hypothalamus to the kidney. And they come from the sympathetic ganglia from T10 to L2. And then the afferent go from the renal pelvic wall, and they're attached to mechano and chemoreceptors that detect things like renal ischemia and increased flow. And then from there, the afferent pathways then ascend to the autonomic centers in the brain and to the contralateral kidney, and therefore a pathology involving one kidney will actually not only affect ipsilateral flow, but also affect contralateral flow. And then both of these fibers run along the course of the renal artery to each kidney and lie primarily within the adventitia, which is the only location where the nerves actually travel together. And as you can see here, these are the postganglionic fibers seen running alongside the renal arteries. And in about 70% of the nerves are located within about 2.5 millimeters of the vessel wall. Which makes them accessible from the luminal aspect. I don't know if you can see my pointer in the top left-hand corner of the screen. They're accessible from the vessel lumen. So the study of muscle sympathetic nerve activity involves a process called microneurography. This is where a thin 200 micrometer thin tungsten electrode is introduced into the perineal nerve in this case. And the result of the test is actually expressed as a burst frequency corrected for heart rate. And when measuring the microneurography in the perineal nerve in patients who are normotensive, you can see how significantly lower the muscle sympathetic nerve activity is as compared to patients who have a moderate hypertension, and then over on the right-hand side of the screen, in patients who have severe hypertension. And the double asterisks they notate that that's a statistically significant difference between each of those classes. And you can see that as the comorbidities increase, there's an additive effect of them, which I'll demonstrate in the next slide. But essentially, these are the conditions that have the most sympathetic nerve activation as expressed or as shown on this microneurography. And so you can see healthy controls over on the left-hand side of the screen there, patients who have lone hypertension, then patients who have obesity, patients who have obstructive sleep apnea in the center, congestive heart failure, metabolic syndrome, and then renal failure. We can see progressively increased amounts of sympathetic nerve activity in those patients. And this is a slide I was referencing earlier. So in patients who have multiple conditions, there's an additive effect. It's not the sympathetic nerve activity is increased. It's not mitigated by the presence of a baseline amount of sympathetic nerve activity. And we've also long known that by modifying the sympathetic nervous system, we can manage hypertension. And before the advent of what's considered modern medical therapy, this was the only way that we could manage patients with severe or malignant hypertension. So in the 1940s, the surgical attempts to modify activity, sympathetic nervous system activity led to the adoption of non-selective sympathectomy. And then this eventually led to thoracolumbar splenectomy. And this was often a multi-stage procedure, often a series of 2 to 3 surgeries, pioneered in Boston by Reginald Smithick and became known as the Smithick procedure. It didn't target the kidneys specifically, but it did result in renal denervation above and below the diaphragm. And despite a very high operative mortality, as well as a pretty inconsistent reduction in blood pressure across all patients who were treated, and despite some pretty disabling post-operative effects, things like severe orthostatic hypotension and hydrosis, patients were willing to have it because mortality was 100% in patients within 5 years of diagnosis of malignant hypertension. And then this was eventually driven into obscurity once we were able to manage patients on medicines in the 1950s and late 1950s and early 1960s. But what remains are more modern approaches to modifying the sympathetic nervous system that can be used to help manage patients who have resistant or multiple drug intolerances and are not able to manage their hypertension. So I'm going to talk about renal denervation for the majority of the rest of the talk, and that's in the top left-hand corner of the screen. So I'll just skip that for a second. In the top right-hand corner of the screen is the baroreceptor activation therapy, so-called BRS. And this is where a pulse generator, along with two leads with electrical stimulators, is tunneled from the generator to around the carotid bulb. Think of it as a pacemaker, and reduces blood pressure by activating a baroreflex over a prolonged period of time. In the bottom left-hand corner of the screen is the AV coupler. This is a percutaneously implanted nitinol device, creating a conduit between the iliac artery and the iliac vein, thereby creating an AV fistula and lowering blood pressure by those means. And then there's in the bottom right, the passive endovascular baroreceptor amplification device, the EBA. This relies on passive activation of the baroreceptor by intermittently changing the geometric shape of the carotid sinus, which will affect pulsatility and wall stretch, and in turn reduce blood pressure indirectly. As far as renal denervation devices, these are the earlier generations of and iterations of the device from different companies. The Medtronic Simplicity, which is arguably the closest to clinical use. This is again the first generation device, 6 French compatible system used for treating renal arteries that are greater than 4 millimeters and treats by ablation, 2 ablations per minute for a minimum, at least initially recommended a minimum 4 ablations per artery. The St. Jude device and a slightly larger caliber device with significantly more ablations per minute, but also more ablations per artery in its initial trials, the Covidian one-shot, and then the Boston Scientific Vessix. And early in the experience, the recommendation was for point-by-point ablations using a series of pullback and rotation motions, and then after each sequential ablation to create a helical ablation pattern in 6 different spots, sequentially from the distal portion of the renal artery all the way to the proximal portion. And you'll note this is treatment within the main renal artery and not into the renal artery branches. And we'll touch on some newer approaches to this a little later in the talk. This is the ReCore Medical Paradise system. This is a different form of denervation using ultrasound, and I mention it here because we'll talk about some of the more recent data for both of these different types of devices. So there's been multiple trials performed of these devices from the late 2000s and the 2010s, and then I will talk about the more recent trials in significantly more detail. The Simplicity spiral and radiance trials were for both catheter-based and ultrasound denervation, respectively, and then there were the trials for the baroreflex activation and amplification therapy. The control trials were of the central iliac arteriovenous anastomosis device, and then there was a second trial of that, which actually ended up being terminated early due to some safety concerns. And then the Moderato trials were exploring pacemaker-based programmable hypertension control therapy. So I want to talk about Radiance 2. This is presented at TCT this year in Boston, which enrolled patients with uncontrolled hypertension who were either not on or were on up to 2 antihypertensive medications. They had to have an off medication, daytime blood pressure of over 135/85, but less than 170/105. They had to have no prior cardiovascular events. They could not be diabetic, and they had to have preserved renal function, and they had to have eligible renal anatomy. Patients were screened. They had a medication washout for 4 weeks. Their blood pressure was then measured, and if they fell into the inclusion criteria, then they underwent anatomic evaluation, and then were randomized in a 2-to-1 fashion for this is ultrasound mediated renal denervation with the Paradise system. And the primary efficacy endpoint was at 2 months to look at ambulatory systolic blood pressure. And then there was kind of longer term follow-ups as well that some of that data we're still waiting on. But the primary efficacy endpoint was of a statistically significant drop in daytime ambulatory blood pressure at the 2-month mark. And the drop seemed to be sustained over 24-hour ambulatory and nighttime ambulatory systolic blood pressure in the renal denervation group as compared to the sham group. And I will say, and something to kind of keep in mind, there's an emphasis on nighttime blood pressure control between midnight and 6 a.m., which you'll see this a lot in the data described as the high risk time, which is when most cardiovascular events tend to happen. And so there's a kind of a special interest placed on kind of sustaining blood pressures even during that time period where maybe medicines are washing out for our patients. And this also showed that it was sustained as far as both mean home and mean office blood pressures. And the changes were seen as soon as 1 month after patients underwent ultrasound guided denervation. And you can see the baseline adjusted home systolic blood pressure as well as office blood pressures lowered in the renal denervation group as compared to the sham. This slide is really demonstrating that this is overall a safe procedure. There were no significant 30-day or 6-month adverse events. And most notably at the 6-month mark was that there was no new onset renal artery stenosis as confirmed by anatomic evaluation. And that's important to note, especially with some of the larger bore devices that were not inducing renal artery stenosis, especially where this is a balloon-based system to make contact with the vessel wall. And when comparing this to other studies of ultrasound denervation, the findings were similar. And so this led the authors to conclude that in patients with uncontrolled hypertension, renal denervation was associated with highly significant and clinically relevant and consistent reductions in daytime and 24-hour blood pressures, and that the blood pressure lowering effect was already present at 1 month, and it was sustained over a 24-hour circadian cycle without any major procedural or device-related adverse events in that time period. So the Simplicity Hypertension 3 trial is the kind of first and the largest randomized sham-controlled trial for radiofrequency renal denervation for patients with uncontrolled hypertension. I will ask you to keep in mind this was the first generation Simplicity device that was studied in this trial. And the 6-month endpoints were somewhat disappointing for those who were hoping to see kind of significant changes, and the only metric that met statistical significance was nighttime systolic blood pressure, so in that range between 1 and 6 a.m. And at that it was about a 5 millimeter decrease in blood pressure in that time period. But the way that the study was designed was that patients became unblinded after about 6 months, and if they continued to meet the criteria for renal denervation, that they could then cross over and be treated. And then what we got more recently was the long-term results of that trial. And so this is just basically a repeat of what I just said here is that they crossed over and were able to be enrolled, and the 3-year data was presented recently, but some patients were followed up to 5 years, although I will say in decreasing numbers, and I'll report that data shortly. And these are sick patients. They have very elevated blood pressures, as you can see at the top of the graph there. They're the patients that we see every day. They're in their mid to late 50s. A little over half were men, about 25% African American. And then there was a good proportion of patients who had significant comorbidities and ones that we see in our practice quite regularly. So almost 50% of the patients had diabetes, almost 30% had coronary artery disease, and about 20 to 25% had to have a history of hypertensive crisis, although they could not have had an admission due to hypertension within the last year prior to enrollment in the study. And the vast majority had been treated for hypertension for well over 10 years. These are the safety endpoints at the 6-month mark. Overall, a safe procedure. But do note the significant number of patients who ended up dying within a 48-month time period of the procedure, just demonstrating how ill the population was that was enrolled. And so what we'll talk about is the long-term follow-up of these patients. So after the 6-month mark, about 101 out of the 171 patients crossed over to renal denervation, and the outcomes were then followed and compared to the non-crossover group, as well as an imputation of those patients who did crossover, basically marking those their findings at the 6-month mark over time. And what they found was that trends over the 36-month follow-up period, the patients in both groups had a similar number of medications, but the patients in the renal denervation group were taking fewer medication administrations per day. It is noted, although not highlighted, that the dosages of the medicines that they were on were also lower, although that's not captured in this graphic. And so what we can see here is that there's actually a significant drop in blood pressure, systolic blood pressure at 12, 24, and then 36 months. And then when we look at the longer term data, which I won't show you, there's no sham group data here because of how few patients were actually followed beyond 48 months. You can see that there's actually a sustained decrease in systolic blood pressure up to 54 months of greater than 30 millimeters of mercury. And again, there's no comparison here, and some of this is based on it's not a randomized group beyond this point. So it's hard to draw hard conclusions from this, but it definitely shows the durability of the procedure and the sustained nature of the effect from the denervation. Similarly, we can see significant changes in office diastolic blood pressures out to 54 months of up to 15 millimeters of mercury. And same again for the 24-hour systolic blood pressure as measured by ambulatory blood pressure monitor. And then a drop of up to 10.2 millimeters of mercury at 48 months in the 24-hour diastolic. And then when looking at the ambulatory blood pressure monitors, you can see that there's a sustained and round-the-clock reduction in patients in the reduction in the systolic blood pressure in the renal denervation group as compared to the controls on the right-hand side of the screen. And this is just a way of looking at the blood pressure distribution of the patients enrolled. And you can see that at baseline, all patients had a systolic blood pressure greater than 160, and a significant proportion had a systolic blood pressure greater than 180. And then when looking at the renal denervation group after 6 months, 57% of the patients were in the greater than 160 bracket, so that's down from 100%. And then if you go out to 36 months, it's actually closer to 31% of patients with truly uncontrolled blood pressure, so significantly reduced over that time period. And you can see that between baseline and 6 months, there was no real significant change in the patients who got the sham procedure, but then those who eventually crossed over to renal denervation after that 6-month mark, by the 3-year mark, had very similar results to those who had denervation in the first place. And so although the patients were unblinded after 6 months, the crossover patients were imputed and carried forward as we talked about. And due to that crossover, the long-term follow-up control was lower, and drug testing was not used to confirm compliance in either group. And so those are limitations to the results, but certainly very encouraging for anyone who was following for durability and significant improvement in blood pressures after denervation. So the final follow-up demonstrated that renal denervation was safe and effective at lowering office blood pressure, both systolic and diastolic, as well as ambulatory blood pressures out to 3 years and probably longer. But probably one of the most important things that came out of this trial was what the trialists learned about ways to optimize either the procedure or onward testing. And so it gave way to the development of the spiral hypertension clinical program to obtain both off-med and on-med data. It was important to standardize medications to better compare the groups, and it was important to measure patient adherence to medicines for basically a better comparison between the two modalities. And some of that is owed to some variation in renal anatomy. So the procedural strategy was adjusted to basically reflect that the renal nerve anatomy is in about 30% of cases is variable in that nerves arriving to the renal artery, the main renal artery, were what are called late arriving nerves. So they weren't actually, although much of the ablation was performed in the proximal portion of the vessel, often there was no benefit to that because of how far the distance that the energy waves had to travel in order to actually reach the arteries, and not providing effective ablation. And it was also noted that the nerves actually wrap around the branches, and with improvements in technology, being able to approach the renal branches became an important goal. And with that came the advent of the multi-electrode catheters, which are smaller profile and able to reach the renal artery branches, as demonstrated here, and allowed for 60-second simultaneous energy delivery to four spots along the renal artery or the renal artery branch. Because of the conformation of the catheter, vessels up to 8 millimeters in size could be treated, allowing for variability in anatomy of different patients of different sizes. So this led to the spiral hypertension off-med trial. So this was a trial of 331 patients that were either drug naive or their medications were discontinued, and then they had a 2-week check-in and a 4-week follow-up, and then 166 patients were randomized to the renal denervation group and 165 to the sham group. And the patients had similar baseline characteristics, similar systolic and diastolic blood pressures. The groups had follow-ups every 2 weeks, at which time they had ambulatory blood pressure monitoring, office blood pressure, and drug testing. Medications were then started, and the patients were followed for 12 to 36 months. There was an unblinding after 6 months, and patients were allowed to cross over at that time once and both the clinicians and the patients were unblinded. So similar safety endpoints that we've seen in previous trials, as far as the safety of the procedure, but no real significant differences there. In this study, the renal denervation group received 18 main artery ablations and 28 branch ablations, with about an average procedure time of 1 hour and a 100% success rate. So at the primary endpoint of 3 months, there was a moderate but statistically significant drop in both office and ambulatory blood pressures. And the renal denervation group had a sustained reduction in blood pressure throughout the day on ambulatory blood pressure monitoring at 3 months. And the authors, again, emphasizing the blood pressure reductions in the kind of high-risk zone of nighttime and early morning. And then this led to the hypertension on med trial. This was recently, the results of which were recently discussed at AHA last month. So similar study design, excuse me, in that patients were enrolled over 2 office visits. They had to have systolic blood pressures of 150 to 180, stable on medications for at least 6 weeks. There was also drug testing to ensure adherence to medicines, office blood pressures, and 24-hour ambulatory blood pressure monitors were measured prior to randomization. And then patients were randomized to either denervation plus medications or medications plus a sham procedure. And these patients were followed over time. So at 6 months, statistically, there was a lowered 24-hour systolic, diastolic, and office blood pressures for patients in the renal denervation group as compared to those who had a sham procedure plus medications. And that there was a sustained reduction in 24-hour systolic blood pressure and office systolic blood pressure, as well as lower blood pressures on ambulatory blood pressure monitoring. It's also noted that 83% of the patients in the renal denervation arm had a 24-hour systolic blood pressure below 140, as compared to those in the 44% of those in the sham arm who were able to maintain that systolic blood pressure threshold. So the primary Bayesian efficacy endpoint of 24-hour systolic ambulatory blood pressure monitor reduction was not met, and this was with a 51% probability of superiority of the renal denervation group versus those who had a sham procedure. But that being said, nighttime systolic ambulatory blood pressure reduction was statistically significant. And the study did meet the pre-specified secondary endpoint of office systolic blood pressure reduction of 9.9 millimeters of mercury in the renal denervation group versus 4.9 in the sham group. They did note that the overall medication, the burden of medications was higher in the sham group at 6 months. And this contributed to what's called a win ratio, which the trialists saw as a kind of a beacon of light or a bit of hope at the end of the trial, despite it missing its primary efficacy endpoint. And with that, the company was touted this clinically meaningful benefit and did file for FDA approval for use of the device in the United States. This is currently pending and waiting to hear when this may be approved. So we do now have multiple sham-controlled trials, both ultrasound and radiofrequency mediated renal denervation, showing a sustained and statistically significant, albeit moderate treatment effect of renal denervation. And with pooled data from the studies, it's clear that there's a blood pressure lowering treatment effect, all while providing a safe procedure for our patients. Talking about other sympathetic mediated conditions that we see and treat often, I just wanted to touch on some data for atrial fibrillation and congestive heart failure. Although this is not something I'm going to dwell on for very long. But for atrial fibrillation, renal denervation, in addition to PVI, did result in a significant, pulmonary vein isolation, did result in a significant reduction of risk of AF recurrence at follow-up, as well as a significant reduction in systolic blood pressure at the 12-month follow-up and an increase in EGFR in patients followed over a 6-month period. Some critique of those studies has been the high recurrence rate of atrial fibrillation in the PVI only group. And so do take these results with a grain of salt, but something that may be worth a closer look. The treatment effect in heart failure is a little bit more interesting. So 2 studies, the diastole and the RDT-PEP, Studies both showed an improvement in baseline E to E prime symptoms, a change in exercise tolerance, and an increase in, an improvement in heart failure biomarkers, as well as a decrease in LV filling pressures in patients who had renal denervation and diagnosed congestive heart failure. And what I've included here are some figures from a pooled meta-analysis showing improvement in NYHA class and a 6-minute walk test in patients with systolic dysfunction, as well as who underwent renal denervation. And also in this same pooled analysis, they looked at left ventricular end systolic and left ventricular end diastolic dimensions, both of which were improved. Again, this is pooled meta-analysis data, so you do have to be careful when interpreting these data. But in someone who follows these patients longitudinally and in the heart failure group, these are exciting findings in a sick population with significant major adverse cardiac events over time. So it remains a challenge to predict which patients are most likely to respond in a meaningful way to this therapy, and ultimately which patients we should be referring for invasive therapy as opposed to those who are deserving of onward aggressive medical therapy, ensuring medication adherence, and emphasizing the importance of lifestyle modifications. We do know that patients who are treated more aggressively have fewer cardiovascular events, but how much of an outcome effect is reflected by the relatively modest BP lowering effect seen in denervation patients is still a question that remains to be answered. And although we do have good data showing immediate and short-term post-procedural complication rates, we do await longer-term data to look at kind of the longer-term safety issues related to the procedure. So as a way to sum up renal denervation, we have over 10 years of intense interest and investigation. We have rigorous sham-controlled trial. We've demonstrated blood pressure reductions on the order of some lifestyle interventions that patients can achieve with modification. We still don't have outcome data. It's a little bit of a jump to say that the lowering of blood pressure caused by renal denervation results in decreased outcomes, although there's very good data that decreasing blood pressure in not necessarily denervation related ways will improve patient outcomes over time. It's not clear where it will fit in a multi-modality approach, but maybe one component of step therapy for some patients. And it certainly highlights the importance of shared decision-making. So I do want to thank you all for your attention. I also want to thank Matt Rivara from the hypertension clinic at Harborview, who kind of helped me to kind of put my thoughts together on this talk, and who I think will be an important ally in kind of future operationalization of this procedure if we choose to pursue it. So thank you.
Thank you very much. So after, okay. Thank you. So after renal denervation, do we have any ideas on the potential for renal reinnervation, like say after more than 3 years?
That's a good question. So, we do have some data on patients in the earlier trials going out to about 54 months and showing that was sustained over time. There's also a registry of patients who've undergone renal denervation with the Simplicity Medtronic system, and that is accessible, and they will be publishing data on that. So if the question that you're asking me is anatomically do the nerves come back, the answer is we don't know. But what I can tell you is that in the patients, the 39 patients that made it to 54 months, they had a sustained and durable result as a result of again, remember, earlier generation devices. We would like to believe that would continue over time. But you're right. I think that we won't know that until some of the registry data is published and is made public.
Durability, the answer is most likely no, they don't relate because it's been 5 years, so it's not going to change.
Fantastic talk. Thanks. 2 questions. Why do we think the efficacy seems to improve after 6 months? I think there's at least Simplicity 3 and a couple other trials that showed that. And then secondarily, are there classes of antihypertensives that are either less effective or contraindicated after a presumably successful denervation?
Yeah, thank you for your question. So the answer to the first question that you had, so if you, it depends on which studies you look at. So if you're looking at the Radiance 2 trial, they actually looked at patients as early as 1 month, and those patients actually had improvements as early as there, and that was maintained at the 2 months, and that's when they kind of, that's where the trial was reported. At the 6 month mark was again just the trial design of the Simplicity trial. It's just when it was looked at. That's not to say that patients wouldn't experience some improvement at.
Questions: why does it change between 6 months and 54 months? Why does it continue? It looks like a trend that the improvements actually get better over time.
Yeah, and it's if that was, if the question was kind of about longer term, I guess I don't have a good explanation for that. Some of it is probably related to the patients. There's a bias. So the patients who remained enrolled, who remained engaged with the trial in the kind of trial follow-ups, are probably the ones who are most likely to be interested in maintaining, the clinical benefit or the blood pressure benefit as far as medication and medication adherence and lifestyle changes. But I don't have a good explanation as to why, at least in most of these trials, and certainly in the modern era trials, why it continued to have continued to improve over time.
Is there any hint as to which antihypertensive therapy superior after you have renal denervation?
They standardized actually the antihypertensive regimens for patients. So it's not like they took out the RAS inhibitors or anything like that for patients who had denervation. So those medicines were continued and continued to provide benefit. So no clear reason to stop those medicines after just because the patients had denervation.
No contraindications to Entresto after.
It would be the standard contraindications to Entresto as far as renal function, et cetera. But no, there was no indication that there was a worsening of renal function post-procedure, even on medicines that you might expect would do that.
It would make sense. Those drugs that you work in, those not good that system, so in theory should happen. Mechanistically, it doesn't make sense at that age.
Thanks. Thanks for the really interesting presentation and well presented. I'm really struck by how large the difference in effect is across the different studies. Some of them showing just huge reductions in blood pressure compared to what we see with even combo medical therapy, and then some showing much smaller. And I'm just wondering, clearly investigators here did a lot of work to develop very thoughtful trial plans. These are very sophisticated trials with sham, with Bayesian approaches. At the same time, they're getting sort of wildly different effects for what, for the most part, seem like reasonably similar interventions. And I'm just curious what your thoughts are on why there's so much heterogeneity in the effect size across the decade of trials.
I think a lot of it has to do with the learned experience from the early trials that then was translated into kind of what we would consider the modern day trials. There was a big emphasis placed on looking at patients who are both on med and off med. And I think a lot of that had to do with concerns about patient medication compliance over long-term follow-ups. And I think that's what's helped to kind of bridge the gap between some of the earlier trials that didn't have a lot of drug testing associated with the follow-up trial protocol. And those that are more recent where all of that was very rigorously kind of assessed. And then you also have to keep in mind that as time goes on, especially after the 6-month mark, the number of patients that are still enrolled in those trials drops off significantly. So there's going to be a significant difference in the how much you can read into that. So I don't know exactly how to answer your question, to be perfectly honest with you. I think that the most recent data would tell us that the treatment effect is probably on the order of something moderate. So something on the order of a sustained lifestyle modification. I think that is probably what I would tell you is probably the most realistic outcome with someone who has this procedure. We were hoping for a holy grail, a one-time procedure that would end all hypertension, and that really has not been borne out. And so I would caution you to look at some of the data from the older trials where maybe they weren't so rigorously followed over time and where the numbers were quite small beyond about the 48-month follow-up. So do be careful with that and kind of manage expectations when this does come to clinical practice, that's probably what you're going to expect is, you know, the effect of losing weight or exercising.
Question from the Zoom.
We have 2 questions from the Zoom chat. The first one is, there seems to be no greater than 70% renal stenosis post-treatment, but is there any stenosis post-treatment? Interesting talk.
I think, thank you. So we have not seen on the follow-up of now multiple trials that there's been any significant renal stenosis following the procedure. And I would say that we're going to learn more about this when the registry data becomes kind of more available. But as far as I know, there's been no patients who've required further therapy for renal artery stenosis following the procedure.
Thank you. And the second question says, excellent talk. As you pointed out, HTN is very heterogeneous. It also looks like some higher risk patients benefit more from the procedure more. Are there any ways to identify those who are more likely to benefit?
I mean, this is the great problem with this procedure is we don't yet know who is going to respond best. And even from the early days of sympathectomy in the 1940s, it was known that patients had variable responses to the surgery. And as such, I would say that as clinicians, the patients who we think would benefit most are those who are have been treated for hypertension for a long time, are either not tolerating or not able to afford or not able to adhere to their medications, and who are not able to adhere to the lifestyle modifications that we recommend to them. Those are the patients that we would probably think about for this procedure. But to say that I could tell you that it's the over 65 or the certain racial demographic that may benefit more, we don't have that data.
Just to wrap it all, thank you very much. I will tell you, having just had to start taking since I started my lipid lowering therapy this year. First of all, I don't know anybody that's drug testing on their patient to make sure that they're not hypertensive. So it does seem sometimes when we get into clinical trials, we run them in a way that nobody in the real world would ever be able to do. And I think we have to be very honest about the fact that medical compliance is at the early years period. I remember back when I was an intern, you were on a once-day drug and compliance rate was 90%, twice a day was 70%, and 3 you went down to 40. So if you're giving somebody that has to take it 3 times a day, they're not taking it fast. So I do think we have to be honest about that. Yes, medical therapy is great, but it's not the panacea. It's easy to give, but it may not be the panacea you want. I think the other piece with renal denervation is like every technical procedure, it's easy to give everybody a pill. Procedures require operator experience, and also we have to develop procedures to be more accurate. We talk about getting out into the smaller branches and things like that. So again, I think these are areas in evolution, but I think it's going to be a nice additive for patients who either can't take their meds or are really resistant to the drugs. So it'd be nice to have this in the future for everybody. So thank you all. I really appreciate it.
Well said. Thank you both.